Hi, my name is Lauren Eisenbud and I'm a hematologist oncologist with Robles. Today I'll be speaking to you about non-chemotherapeutic options for breast cancer, which I find to be a very exciting talking point. In oncology, there's a big move to try to move from the traditional one-size-fits-all chemotherapy to more precision medicine. And precision medicine is drugs and treatment options based on tumor characteristics, including tumor genetic mutations and also patient genetic mutations. And what's great is a lot of these drug options tend to be a lot better tolerated than chemotherapy. But before I talk about that, let me first start off with the different breast cancer subtypes. Now, we have three different proteins that can be present on our breast cancer cells. We have our estrogen and our progesterone receptors. If these are present on the breast cancer cells, this is termed hormone-positive breast cancer. Our second is HER2 positive breast cancer, and this is when there is an accumulation of the HER2 protein on the breast cancer cells. And thirdly, we have our triple negative breast cancer, and this is when none of these three proteins are present on the breast cancer cells. About 65 to 75% of all breast cancers are hormone positive, whereas 15 to 20% are HER2 positive, and the other 15 to 20% are triple negative. Now let's talk about the treatment options for hormone positive breast cancer. Traditionally, majority of women with both early stage and metastatic breast cancer required chemotherapy. Now, early stage breast cancer is breast cancer confined to the breast and possibly has spread to the lymph nodes in the armpit or the axillary lymph nodes. Whereas metastatic breast cancer is breast cancer that is spread from the breast and the lymph nodes to other organs in the body, like the bones, lung, liver, etc. Nowadays, about 50% of all women that are diagnosed with breast cancer have just breast cancer in the breast itself without any involvement of the lymph nodes. Of these women, about 70% can actually safely avoid chemotherapy, which is really an astounding number. Even for women that are postmenopausal that have cancer in the lymph nodes, a good number can also safely avoid chemotherapy. So how do we know who needs chemotherapy for these early stage breast cancers? We have a tool called the Oncotype DX recurrence score. This is a test that looks at which genes are turned on in breast cancer cells. And based on this, we can determine whether or not chemotherapy is beneficial for a particular patient. Now, for metastatic breast cancer, unfortunately, chemotherapy remains kind of a mainstay for these patients. However, we have a lot of treatment options that patients can receive prior to chemotherapy. Our first class of treatment options is hormone-directed therapy. Our options are tamoxifen, which is typically reserved for premenopausal women, and aromatase inhibitors, typically reserved for postmenopausal women. Both of these are pills, so very, very convenient. Additionally, they are very well tolerated, and they're used for both early stage and metastatic breast cancer. For metastatic breast cancer, we have a third hormone therapy called Faslodex. Faslodex is an injection, so not as convenient, and it's given once a month. But there's actually ongoing clinical trials looking at a pill version of Faslodex, which would be very beneficial for this group of patients. Our second class of therapies is CDK4/6 inhibitors. We have three drugs. We have three CDK4/6 inhibitors. We have Ibrance, Kisqali, and Varencia. These are all pills. They're all equally efficacious, but they do have varying side effect profiles. They're routinely used in the metastatic setting. However, really in the past year or so, I think it was January of this year, Varencia was actually approved for women with early stage breast cancer with a high risk of recurrence. So this is another tool that these women have to further reduce the rate of the cancer coming back. As healthy breast cells develop into cancer cells, they acquire mutations in their genes or their DNA. Now, this is not mutations in the DNA or genes that the patient is born with, but only in the tumor itself. And what's really exciting is we actually can sometimes target some of these mutations with drugs to help fight off the cancer. So for all women with metastatic breast cancer, they should have mutation testing on their tumor. Again, this is to look for the mutations to see if we can target them with a drug. One mutation in particular we've identified is PIK3CA, and the drug that targets it is Piqray. Piqray is a pill, and it is routinely used in the metastatic setting for hormone receptor positive breast cancer. Now that was the tumor profiling. We can also do genetic profiling on the patient themselves. And this is looking at the patient's own DNA or genes to see if there was any mutations that they were born with that predispose them to develop the breast cancer. And this is important because if they have a particular mutation, it can also increase their risk for other types of cancer. One of our societies, the National Comprehensive Cancer Network, recommends that all women with breast cancer undergo genetic testing to see if they have any of these genetic mutations. One of the genetic mutations that we found is the BRCA1 and BRCA2. This is typically seen in Ashkenazi Jewish population, but of course is seen in other populations as well. And for these women, we found that we have a particular class of medication called the PARP inhibitors, which are very useful for these patients to help fight their cancer. PARP inhibitors are pills. They are approved for both early stage and metastatic hormone receptor positive breast cancer, and they're also approved for early stage and metastatic triple negative breast cancer as well. Now let's move on to HER2 positive breast cancers. For women with HER2 positive breast cancer, chemotherapy remains an integral part of their treatment algorithm. However, we do have very good HER2-directed therapies. One class of HER2-directed therapy that we have are called monoclonal antibodies. These work by binding directly to that HER2 protein on the breast cancer cell to help kill off the cancer cell. We have two options. We have Herceptin and we have Perjeta. Both of these are infusions, however they can also be given as injections, and for the most part they're very well tolerated, and they're approved in both the early stage and metastatic HER2 positive breast cancer. Our second class of medications is antibody drug conjugates, or ADCs. We have three ADCs. We have TDM1 and HER2 and Kadcyla. Now ADCs have a monoclonal antibody, again that attach directly to the HER2 on the breast cancer cell, but they also include a drug. So when the monoclonal antibody attaches to the HER2 protein, the drug enters into the cell and destroys the cell. So they're a little bit more potent than the monoclonal antibodies. Now these three drugs that we have are infusions, and they are for the most part used for metastatic HER2 positive breast cancer. TDM1 in particular is also approved for some women with early stage HER2 positive breast cancer. Now there's another class of breast cancer called HER2 Low. Now as I spoke about, HER2 positive breast cancers are breast cancers where there's an accumulation of the HER2 protein on the cell surface. You require a particular amount of the HER2 protein to be considered HER2 positive, but for these HER2 low patients, you can have an accumulation, but it's just less than what is required. Now, this accounts for about 50% of all patients with breast cancers, which is a huge number. And what's really exciting is within the past couple months, HER2 has actually been approved for this patient population as well. So this is great to give them another treatment option. Now, moving on to triple negative breast cancer, chemotherapy unfortunately really is the mainstay for this type of breast cancer. However, we do have two treatment options that are non-chemotherapeutics. We have immunotherapy, in particular Keytruda. Immunotherapy works by boosting the patient's own immune system to recognize and fight off the cancer. It's approved for some women with early stage triple negative disease, and it's also approved for patients with metastatic triple negative disease. We also additionally have an antibody drug conjugate called Trodelvy that is approved for the metastatic setting as well. And as I mentioned before, the class of medications called PARP inhibitors is also approved for the triple negative breast cancers. Now I know that was a lot of information and it was a very dense subject, but I hope that I provided some useful information for you. Unfortunately, for a lot of women, chemotherapy is still an integral part of their treatment. But as you can see, we have a lot of really good treatment options that are not chemotherapy, and I know that this list will continue to grow in the future. Thank you very much.